Talking about hepatitis B therapy and approaches to cure, which I think we could also probably title, How Do We Do for Hep B What We've Done for Hep C? And I think there is a lot of excitement, and it really has been amazing to see what's happened in Hep C, and now to see some of that excitement rolling over into Hep B with a lot of activity in both on the basic science level, translational science, and now moving into clinical development of new therapies. So here are my disclosures. And so what I'm going to do is talk about the goals of therapy, why we need new treatment, or if we need new treatment. I'll touch on that a little bit, and then approaches to the new treatment. And that's really where I'll spend most of my time on both virological and immunological targets. So I think in terms of the goals for therapy, we take it from the natural history. Unlike hepatitis C, curing this infection is a lot more difficult. So we really look at trying to prolong survival, ultimately, and reduce the risk of liver cancer. And if you look at that, you can see that in patients that remain inactive, even if they have persistence of surface antigen, they have a very good long-term outcome. But you can see that if they clear surface antigen, really the risk of cancer almost disappears, and that's really the goal of therapy. So either very inactive disease or ideally surface antigen loss are associated with excellent long-term and cancer-free survival, and really has become essentially the goal for therapy. Trying to prevent these long-term complications is the goal, but it's challenging to study these because obviously they take too long, and this is really makes the use of surrogate endpoints quite critical. So people have talked about truly curing the infection, and this would mean that you get rid of all traces of hepatitis B from the liver, sort of like we've done for hepatitis C, or at least so we think. So there would be no traces of the virus, and this is very difficult. Some argue it's even impossible to get rid of the viral genome, the CCC, or covalently closed circular DNA in the hepatocyte nucleus, which is long-lasting and stays there at least as long as hepatocytes survive, and possibly even survive cellular division. So this is really a challenge. So most people have focused on functional cure, and we really use the markers of natural history to define what this looks like. So ideally, we'd like to see surface antigen loss, and ideally with the development of antibodies to surface antigen. And I'm going to talk a little bit more about this in a moment, that surface antigen loss may not always mean the same thing. But I would argue that possibly just sustained off-treatment inactive disease without surface antigen loss, and in this case we would be looking for E-negative disease with undetectable HBV DNA, normal liver enzymes, and normal liver histology. We know from the natural history that this actually holds for a very good prognosis, and so if we could do this, even without surface antigen loss, that might be adequate. I think the challenge with doing this is it requires long-term follow-up because these patients don't have a clear marker, at least with our current biomarkers, to indicate that they won't have a relapse of their disease. Whereas those that lose surface antigen, we know from long-term natural history studies that they tend to stay surface antigen negative and less severely immunosuppressed. So cure is not so simple, and the reason really does lie in the virology. If we think about suppression, we can do that with our current agents, with the nucleotide and nucleoside analogs. You can see with long-term entecavir therapy, or with tenofovir, either alone or combined with emtricitabine, you can see very high rates of HBV DNA suppression. And it really does occur in almost all patients. Even after patients have developed lamivudine resistance, you can still see that we can get almost all patients eventually to become virus undetectable. But the problem is suppressive therapy with virus is not the same as suppressed therapy without drugs. So patients that do this on their own have a better natural history than those on therapy. And this was nicely shown in this large Korean study where they looked at patients who were treated with nukes versus patients who had naturally occurring inactive disease. So in both groups, they had undetectable HBV DNA and were e-antigen negative, but what you can see is that the patients here, the ones who controlled virus on their own, had a lower incidence of liver cancer, both in non-cirrhotic and cirrhotic patients, than those who did this on therapy. So this means that treatment's effective. It reduces the risk of cancer, but spontaneous immune control is better than suppressing the virus with treatment, and that means we need to think about ways to stimulate immune control off therapy without just blocking viral replication. And so if we think about nukes, why don't they actually lead to cure? Well, just as a brief reminder of the viral life cycle, the virus enters with the envelope is taken off, and then the nucleocapsid comes off, and the HBV DNA is taken to the nucleus, where it is repaired to form this partially double-stranded DNA template is repaired by cellular mechanisms to form covalently closed circular DNA. And this is this long-lasting episomal form of the virus, which is very persistent. This also serves as the template for viral replication and leads to the production of a number of RNA species, the most important being the pregenomic RNA, which is the template for viral replication, as well as other protein transcripts. So these come from the envelope proteins, the surface antigens, are made from the subgenomic RNA transcripts as well as E antigen, and the pregenomic RNA can be translated to make core protein and the polymerase protein. This is then all packaged, so this pregenomic RNA is packaged with these core proteins that self-assemble into a nucleocapsid along with the polymerase protein, and then this encapsulated pregenomic RNA is reverse transcribed by the polymerase that is present there to make HBV DNA. And that HBV DNA can then either be recycled to replenish the supply of cccDNA within the nucleus, or it can be coated with envelope proteins and then secreted from the cell as a new infectious virion. And really the key points here are this long-lasting cccDNA, which is really the challenge, and secondly is this replenishment of cccDNA that occurs, and we know that the fact that you see persistence with potent nuke treatments means there is a leak. So, and I'll show you what I mean by that. So, at least if I go back, in theory, if this was completely blocked, eventually you would have cccDNA loss over time. But this study, I think, really nicely showed that that doesn't happen. So these were actually HIV co-infected patients who were on long-term tenofovir therapy and underwent liver biopsy. And what you see is that a couple of things you notice here. That first of all, it takes a long time to see any cccDNA decline, and it never goes to undetectable levels in the liver, even in patients on long-term suppressive therapy. But I think what's more important here is that you continue to see intrahepatic non-cccDNA within the liver. And so this very slow decline and persistence of cccDNA and detectable intrahepatic non-cccDNA support ongoing replication. This means that despite what we call complete suppression, so you have undetectable HBV DNA in the serum, there is a leak, there is replenishment of cccDNA that's continuing over time. We can't detect it in the blood, but it's happening in the liver. And this recirculation probably restores infection within the infected hepatocyte and may also lead to de novo infection. So the consequence of this is if you're going to cure an individual, you either need a very, very long therapy, some estimate that over 50 years would be required based on the kinetics, or you need a new approach to treatment. So what's the problem with our current therapies? Well, if we think about the nukes, they're good at suppressing HBV DNA, but they have little or no effect on immune control. So if you take patients off treatment, they tend to relapse. So you have a high risk of relapse unless they've cleared surface antigen. And unfortunately, there's very low rates of surface antigen even with long-term therapy. So the consequence of long-term therapy, of course, these drugs are pretty safe, but when you start giving them for decades, you worry about even rare safety concerns, obviously the costs, monitoring, and the reality is that access in most of the world where hepatitis B is a problem is very limited. What about interferon? Well, you do get slightly higher rates of surface antigen loss and you have finite therapy, but it's pretty poorly tolerated, so the reality is neither patients nor providers want to use this drug, and so really we're in a situation where we do have pretty good therapy, but neither approach is ideal. But it is important to remember that the therapy we have right now isn't bad. So if you compare hepatitis C and hepatitis B, when we started to look for new treatments for HCV, we had very ineffective, very poorly tolerated therapy. With Hep B, we actually have very well-tolerated, very effective therapy. So this is a pretty high bar, and it's important to remember this because patients aren't going to trade their well-tolerated once-a-day nukes for a toxic therapy, even if it leads to a higher rate of off-treatment suppression. Hep C has multiple life cycle targets. HBV has just the viral polymerase as an enzymatic target, which makes drug development more challenging. Hep C doesn't have this long-lasting nuclear reservoir or integration, so like Hep B or HIV, whereas cccDNA is very persistent and hard to get at. And at least Hep C, it doesn't seem that you need much involvement of the immune system to get viral control or clearance, whereas with Hep B, immune control seems quite critical. And this is an issue because it means that our therapies might lead to flares. And flares are difficult for us to manage, they're potentially difficult for patients to tolerate, and they do raise significant safety concerns. So the bottom line is it's not going to be as easy to cure Hep B as it was to cure Hep C, and I think that's why there's excitement in this field, but there are certainly challenges to getting there. So how can you do this? Well, we can do viral targets, more adding to the list of direct-acting antivirals, or we can target the immune system. And if you look at a long list of potential viral targets, and I'm going to go through these from entry to cccDNA targeting directly, the RNA intermediates, encapsidation, DNA replication itself, assembly and release. Or on the immunomodulatory side, you can look at either the innate immune system or the adaptive immune response, and I'll talk about those at the end. So if we look at the potential targets in the life cycle, so we can try to block entry, we can target cccDNA directly, either trying to destroy it completely or inactivate it. We can target HBV Rna, so the transcripts, block encapsidation, DNA synthesis, assembly, and export, or we can try to get the immune system to do this job for us by either the innate and/or adaptive immunity. So let's start with blocking entry. The discovery of the hepatitis B receptor was an important discovery and coincided actually with the recognition of a blocker for the NTCP, the sodium taurocholate co-transporting peptide, which is now believed to be the primary HBV receptor, which is predominantly expressed in the liver. And this peptide, this lipopeptide that is known by the name Mercludix-B, was actually designed even really before the receptor was identified, but was shown to bind very tightly to the HBV receptor and prevent viral entry. And so the nice thing here is that because it's blocking the envelope binding, it blocks not only Hep B entry, but also HDV or delta entry, which is important because currently we have few or no therapies for delta. So this drug has actually gone into clinical trials at this point, and there have been, and development continues, and you can see that at least initial studies show some modest but clear effect of this therapy. So you can look with hepatitis B, you can see that a decline in HBV DNA during Mercludix-B therapy, and I think perhaps more importantly with HDV, you also see a decline in HDV RNA. The challenge with this approach is, at least so far, the data would suggest that you get a relatively modest HBV DNA decline. You get no effect at all on surface antigen, quantitative surface antigen. There are some safety concerns because this drug binds the receptor quite tightly and may have long-term lipid effects, which are the natural substrate for this receptor. And at least so far, the effect looks to be greater than in HDV, or greater in HDV than in Hep B. So I would say this may be an adjunctive therapy. It's unlikely to be effective on its own. There are other approaches looking at entry, but this is by far the furthest along at this stage. Now, I want to spend a second talking about surface antigen loss, because we should make sure that we're always talking about the same thing. There are different ways of getting to surface antigen loss, and they may not all be equal. So the goal of surface antigen loss and why it's been targeted as functional cure of therapy is that it's believed to be a loss of surface antigen transcription. So we think that if you get rid of surface antigen production, you're basically turning off the active viral replication, active cccDNA transcription. And eventually you either have silent or maybe even absent cccDNA, which is ultimately the goal of what we're trying to do. So in theory, if you eliminate cccDNA, then you will get rid of all the downstream life cycle events, which is a good approach. Alternatively, if you actually just turn it off, so if you have transcriptional silencing, you will still have cccDNA in the liver, but everything downstream then stops as well. And I think both of these would be very acceptable goals of therapy with surface antigen loss. But there's another way to get rid of surface antigen. So you could also block surface antigen translation. And this is important because this actually has been an approach that's gone into clinical development using siRNA. And I would say, at least to some degree, it's unclear what this means. It may still be very helpful, but it's unknown if it's the same as this, if it's the same as losing cccDNA transcription. So if you block the RNA transcripts and you just degrade them, you will lose protein production, and that may have benefits, particularly because it's thought that the viral proteins, particularly the surface antigen, lead to an immunosuppressive, at least the HBV-specific immune response is exhausted and depressed because of protein production. So this could lead to immunostimulatory responses, but it's unclear if surface antigen loss that results directly from blocking viral translation is the same as when you block it upstream, which is usually what we think of when patients lose surface antigen through the natural history. And finally, we have this additional issue that surface antigen may not come from cccDNA at all. So the other thing that happens with Hep B is that the virus integrates into the host genome, and at least in some instances, it's believed that you can get a properly formed, fully functional surface antigen, so that the whole protein, it will be in frame and actually produced from integrated DNA. And if this is the case, if you actually get surface antigen being produced from integrated DNA, it's theoretically possible you could have cured the infection, got rid of all the cccDNA, and still have a person who's surface antigen positive where it's being produced coming off of the host genome. So this, you could end up with that situation of no cccDNA and still remain surface antigen positive, and you would falsely think that you had not led to a reduction in the virus in the cells, and at least we think that it's probably required to have the whole viral life cycle to promote carcinogenesis and the other complications of disease. Now, whether surface antigen, integrated surface antigen on its own has any negative effects is unknown, but not believed to be the case. So I wanted to put that in because as we think about these different approaches, it's important to think about where we're actually, what we're actually doing and whether this is achieving what we think we're achieving. So if we actually target cccDNA, there's a few approaches to do this. You can either target the formation of it, so the conversion of relaxed circular to covalently closed circular DNA, or you could potentially block the HBV DNA recycling that I showed you before. Alternatively, you could directly destroy it, so destroy the existing pool, or finally, you could silence it, where you block transcription of cccDNA. And this is important because this will have dual effects. Remember that the pregenomic RNA, that this transcript is the template for replication. So if you block production, if you block cccDNA transcription, even without destroying it, you will block HBV DNA production because there'll be no pregenomic RNA. And in addition, you will also reduce antigen production with its exhaustive phenotype complications. So how do we do this? Well, there are a few approaches. From the formation side, some studies that were done a few years ago but looked promising, and I would say still very early days, using these disubstituted sulfonamides that seem to prevent the formation of relaxed circular to cccDNA. Look promising, but still very early, and I'm not sure if these will go forward into clinical development. For degradation, the CRISPR-Cas9 approach seems very promising. It's been obviously touted for many things, but the concern here, as it is with every other field, is delivery off-target effects and whether you can do this safely. Blocking transcription is another approach, and so far the only real convincing evidence that this has been done effectively is with histone acetyltransferase inhibitors. These at least have been shown to block cccDNA transcription in vitro, and there are a couple of case reports of patients on the drugs that block this having reactivation of hepatitis B, suggesting that this is an approach, but of course blocking this is a potentially very dangerous issue. The specificity would be very hard to control to block only cccDNA transcription without blocking transcription of other host products. So I would say in terms of cccDNA targeting, we're still very early on. What about targeting HBV RNA? Well, I already mentioned the siRNA approach, and the nice thing about hepatitis B for this approach is that you've got overlapping reading frames in the viral genome. And the importance of that is that this makes mutation of this virus much more difficult for the virus to tolerate than HIV or hepatitis C. These overlapping reading frames mean that mutations in a single reading frame will often affect, or in a single spot will often affect more than one gene, making it more likely to be deleterious, especially with the very small genome that HBV has. So there are some fairly conserved regions, which means you can target actually all of the HBV gene products, the production of the mRNAs that lead to protein production, as well as the pregenomic RNA that leads to viral replication. So this is attractive and actually has gone into clinical development with a few different approaches using different RNAis. And this is just showing you this one, the ARC520, where you can see a reduction in all of the different viral proteins, surface antigen, correlated antigen, and e antigen. But importantly, you see this very big difference in surface antigen decline between the E-positive patients, who seem to have a good response, whereas E-negative patients have a much reduced response. And at least the theory for this is that perhaps in these E-negative patients, primarily this is coming from integrated surface antigen rather than from cccDNA, and the siRNA doesn't target the integrated viral transcript. That's at least a theory. This looked to be well tolerated, but it's now on an FDA hold because of some concerns primarily about the delivery system, and it's being reformulated to look further. A different RNAi, this one made by Arbutus, you can see that in nuke-suppressed patients, you see suppression, and interestingly here, you don't see that difference between E-negative and E-positive patients. You can see that they all really do similarly. And so at least I think this has raised some questions about whether or not that explanation of integrated HBV DNA, integrated surface antigen being the cause for the lack of effect in E-negative patients to be questionable, at least, because this hasn't been seen with other targets. So what's the bottom line here? I would say it's an attractive approach because it inhibits both viral proteins, which may allow for immune restoration, but this actually has not been that well proven to date. It also inhibits viral replication directly because of degradation of the pregenomic RNA, and it should work across genotypes. There's a relatively high barrier to resistance, but of course this would still be susceptible to mutation. The major challenges here are delivery, the effect in E-negative patients, especially if this integrated DNA leading to surface antigen production is real, and safety is still a concern. So what about moving on down the list, targeting, to packaging? And so the core protein is actually quite an attractive target. It's highly conserved. It does a whole bunch of things in the viral life cycle. I've listed many of them here. And the nice thing is it's all allosteric regulation. So if you could bind or interact with the core antigen, you potentially block all of these steps in the viral life cycle and have a potentially quite profound effect on HBV DNA replication. And this has been approached from a variety of different strategies. The phenylpropanamides were a group of drugs that were developed a number of years ago that inhibit packaging, so you basically get empty capsids. Whereas some of the other newer drugs go by the name capsid assembly modulators or CPAMs, and the reason that they don't like the name capsid inhibitor is they actually accelerate capsid formation, but they primarily prevent encapsidation of pregenomic RNA and the polymerase. So you sort of get empty capsids, which don't lead to viral replication. There are better agents in the pipeline, and I think this is a promising area, but it's pretty early, very little in terms of clinical development at this stage. What about DNA synthesis? Well, this is where our current drugs work, and there are a lot of new nukes in development. Of course, TAF has recently been approved for HIV and for hepatitis B in many parts of the world, and it looks to be basically a slightly more effective mostly because of safety. It has relatively similar kinetics, at least in the blood, but it's not so clear what's happening in the liver. It's interesting that we've seen repeatedly now faster ALT normalization in patients with hepatitis B, and at least it raises the question to me of whether you're actually getting a deeper suppression of HBV replication that we're just not able to detect in the serum because of the sensitivity of our assays. That being said, I think this is unlikely to be the cure. It's likely to be combined with other agents, and really its benefit here is improved safety. possibly greater potency. And interestingly, there have been some approaches to also target the RNase H activity of the polymerase protein, which may improve potency of inhibition. And there are a number of other largely tenofovir variants that are in clinical development, some in relatively late stage development at this point. So I think there will be TAF and TAF-like molecules, which is nice because at least we'll have very safe drugs that we can use with a high barrier resistance. So what about assembly and export? Well, here there was some interesting approaches to this a long time ago. You can see that this is a paper published almost 20 years ago, blocking the glycosylation of HBV proteins. It did seem to block secretion of surface antigen in vitro and in woodchucks, but this was recognized a long time ago, hasn't really progressed. In terms of newer approaches, probably the most interesting thing is this agent Rep9AC, which blocks secretion of empty surface antigen, not virus. The data so far look very good in terms of seeing surface antigen loss, but the mechanism of how this works isn't so clear, and some of the data haven't been as well presented with all of the information to be certain about the details. But I think this is an interesting approach. And finally, we can go on to the stimulation of the immune system. So there's been a lot of work trying to understand how hepatitis B interacts with both the innate and the adaptive immune response. Hep B is thought to be so-called stealth virus with relatively little activation of the innate immune response upon infection, and seemingly controls the adaptive response through T-cell exhaustion primarily. So a variety of approaches at immunotherapy have been proposed on the innate side, giving cytokines, particularly interferon, TLR7 and other TLR agonists, RIG-I agonists. And on the adaptive side, therapeutic vaccines have been considered for a long time, and more recently, checkpoint inhibition has been proposed. So the idea here is that you might lead to immune restoration through inhibition of viral antigens as an additional avenue, combining the viral and immunomodulatory sides together. So one of the arguments for that is that there are data suggesting that if you can suppress HBV, you can improve, you can at least somewhat improve adaptive immune responses or innate responses, in this case the NK cell response. But this is one of the few papers that have actually shown this. A lot of studies have talked about it, but they're actually relatively, this is always referred to in the literature, but actually the data supporting immune restoration with either protein or viral inhibition are relatively limited. So, for example, this study looked at adding interferon to a nuke, so you have suppressed patients with entecavir, and you see that if they get entecavir, if they get add-on interferon, you can see they improve their suppression of DNA, but more importantly, they have a reduction in surface antigen titer. Unfortunately, the response rates are still relatively low here. There's no interferon alone control arm, so not all that convincing, and I think given the toxicity profile, this is probably not the answer. What about TLR7? So you're aware this is a pathogen recognition receptor and triggers interferon responses, and you can see when this oral TLR7 agonist is given, you can actually see nice production of interferon alpha with, at least in animal models, relatively limited systemic side effects, and in a chimp model, good suppression of HBV DNA and some suppression of surface antigen, and there is an ongoing phase 2 trial of looking at an oral TLR7 agonist in patients suppressed with tenofovir. So interestingly, there's a RIG-I agonist also in clinical trials, but these are very early days, and so far the effects that have been seen have been relatively limited. On the adaptive side, people have talked about therapeutic vaccines for a long time. From this Ptarmigan, which is a modified yeast expressing HBV proteins. Nice thing about this, it's very scalable, and there are studies ongoing, but so far they have not yielded very promising results. Other approaches to making therapeutic vaccines, but at least so far, although I think this is still an interesting avenue, the results have been relatively disappointing. And finally, the checkpoint inhibitors. Basically, this is taking off the brake on T cells, and we believe leads to immune activation. This has been a very promising area in oncology with lots of checkpoint inhibitors being approved and showing remarkable effects in immunotherapy for oncology. PD-1 looks particularly attractive target in HBV because you can see that of these checkpoint inhibitors, you can see that PD-1 is the one that's most reliably expressed, and PD-L1 PD-L1, its ligand is expressed on liver cells during hepatitis. So this was a study that was just presented this year at EASL and looked at nivolumab in patients who were nuke suppressed, and they were treated with low-dose nivolumab. And you can see that they just got this initial dose and then were looked at in follow-up. Or got this along with the Tarmogen vaccine, which seemed to add little, so I'm not going to focus on that much more. So what you do see is that there is a little bit of surface antigen decline, but these numbers aren't dramatic. But interestingly, they did actually see high receptor occupancy of PD-1, even with this low dose of just 0.3 milligrams per kilogram that was given. But they did have this individual patient that had a very nice response. So you see that this patient went on, had the dose here, and then you can see that a few weeks later had this fairly significant rise in ALT up to about 250 or so, and the surface antigen titer declined, and 8 months later, the patient remained surface antigen negative and anti-HBs positive. I think this is an interesting proof of concept. This was only 1 of 12 patients, and this was similar to the response that was seen in a hepatoma trial, including patients that had Hep B-related hepatoma. So this is interesting, but this was a significant flare. This patient didn't become jaundiced, but did have a pretty big rise in ALT, and this may be a challenge for practitioners to manage this. So it's not just choosing the right compound, there are also major issues with trial design. So you need the correct population. Do you go for those with the highest need or the easiest to show an effect? You could make a case for studying any of these groups of patients. You also need the correct endpoint. I've made the point that surface antigen loss sounds appealing, but it may not be the same when you achieve it with a nucleotide analog as when you achieve it by blocking translation with siRNA. We may need to look in the liver, and I think some of the new biomarkers like Hpv Rna and HBV correlated antigen, which may also give us a signal about cccDNA transcription, might be quite useful. And then we need to think about these combinations. There's lots of possibilities, which is promising, but they raise very significant issues about safety, especially with the immunotherapies. And remember that these patients are starting with well-tolerated nukes that are pretty easy to take but need to be taken long-term. And you could really think about combining 2 viral targets, different viral approaches, 2 immune targets, or a viral and an immune target. And really, these aren't meant to be specific combinations that you would try, but just to show you that there are lots of possibilities. Probably want to suppress virus, the HBV DNA replication. I think the idea that you'll need to deplete viral proteins is important to if this idea that immune exhaustion is an important part for blocking control, and then maybe adding immune therapy. So you could think about various ways of combining these different approaches to get you to your ultimate goal. You may not need to do all 3 of these things. You may need to do more. The truth is it's a little difficult to know. So at this point, I think we have many virological targets. All of them have at least some challenges. The most promising and the furthest along in development are entry, and at this point, the siRNA approaches. We have fewer immunological targets, and I'd say right now the checkpoint inhibitors have probably shown the most promise, but there are studies going on with the others. And bottom line, it's going to be much more challenging than Hep C, both scientifically and clinically. We have a much higher bar. It's much more difficult to study, but I do think we have some interesting times ahead. Be happy to take any questions. Thank you.